I would like to thank SAGES for the opportunity to present our work. My name is Heather Carmichael, and I am a surgical resident at the University of Colorado. I will be presenting the results of a prospective cohort study looking at patient activity before and after inguinal hernia repair. I have no disclosures. I would like to start off with a case. You see a 68-year-old man in your clinic before elective inguinal hernia repair. He would like to have his surgery done using a minimally invasive technique. After discussing the procedure, he has several questions. He asks, when will I be back to normal after surgery? And, is this better than open surgery? Inguinal hernia repair is one of the most common procedures performed by a general surgeon in the United States. Minimally invasive, or MIS, repair of inguinal hernias using laparoscopy or the surgical robot is increasingly common. MIS hernia repair has been shown to have similar rates of recurrence and chronic pain as compared to an open technique, but must be done under a general anesthetic. Some studies have shown less subjective acute pain as well as faster recovery in terms of return to work and missed hours of work. However, these measures of recovery can be confounded by the type of job the patient has, as well as surgeon direction with regards to return to work. There is the potential to remedy this with the use of wearable activity devices. This technology is becoming ubiquitous and can allow us to provide quantitative and patient-centered measures of recovery after surgery. We have previously shown that wearable devices can be used to track steps per day before and after surgical procedures in order to examine recovery trajectories of activity. We found that recovery differs based on the type of operation and type of hospital stay. The goal of this study is to apply this technology to examine differences in recovery trajectory between patients undergoing MIS versus open inguinal hernia repair. Our hypothesis is that patients undergoing MIS unilateral hernia repair have faster return to baseline activity, as measured by steps per day, compared to those undergoing an open repair. In terms of our methods, this was an IRB-approved prospective cohort study. We recruited patients undergoing many types of surgery, including inguinal hernia repair, which was the topic of this sub-study. Patients wore a Garmin VivoFit watch. This validated device was chosen because it's battery-powered and has a relatively large storage capacity, so that patients did not have to charge the device or upload data at home. Patients were asked to wear the watch continuously and were blinded to their daily step count. Patients were recruited at a preoperative visit. Data were collected for a period of 3 to 10 days preoperatively, and then the device was removed and synced during the patient's operation. The patient then continued to wear the device during their inpatient stay and after discharge. Data were again uploaded from the device at the postoperative visit, and patients returned the device at 4 weeks postoperatively. We defined percent recovery as the ratio of steps per day on each post-op day to the average preoperative baseline. This allowed us to generate recovery trajectory curves using smooth conditional means. Generalized linear mixed effects modeling and unpaired t-tests were then used to compare differences in recovery trajectories of steps per day by type of hernia repair. We enrolled 97 inguinal hernia patients in the study. 10% of patients dropped out of the study during the preoperative period, generally because their operation was canceled because they lost or stopped wearing the device, or because of an issue with the data upload at the time of surgery. An additional 16% of patients dropped out of the study at the time of surgery or early in the postoperative period. This left 71 patients, or 73% of the original sample, who completed the study with at least 2 weeks of postoperative data and were included in this analysis. The study population was entirely male, reflective of our VA patient population, with an average age of 64 years. Patients were generally healthy with overall good functional status and few major medical comorbidities. Patients took an average of just over 6,400 steps per day at baseline, which is the equivalent of about 3 miles and fairly typical of U.S. adults. Most patients underwent outpatient repair. Almost half of patients underwent open unilateral repair. 14% underwent MIS unilateral repair and 30% MIS bilateral repair. There were no significant differences in baseline characteristics of the groups. We first compared the recovery trajectories between patients undergoing unilateral repair, either via an MIS technique, shown here in red, or open technique, shown here in blue. On these graphs, the y-axis represents percent recovery of steps compared to baseline, with the dashed line at 100% representing a full recovery to prior activity. Both groups experienced a statistically significant drop in steps per day from baseline on postoperative day 1, reaching baseline steps per day 1 to 2 weeks postoperatively. We found no differences between these overall trajectories using mixed effects modeling. We then compared recovery trajectories of patients undergoing a bilateral MIS repair, shown in blue, to unilateral MIS repair, shown again in red. There were no differences between these recovery trajectories of steps per day. We then looked specifically at percent recovery immediately following surgery on postoperative day 1. We found that the open unilateral group was closer to baseline activity at an average of 45% recovered, which was significantly higher than either the MIS unilateral or MIS bilateral groups, where patients were only around 25% recovered. There were no statistically significant differences between groups at 1 week, 2 weeks, 3 weeks, or 4 weeks post-surgery. Contrary to our original hypothesis, we did not find faster recovery after MIS inguinal hernia repair using this novel method. Indeed, the only significant difference we found between groups was that the open unilateral hernia repair patients took more steps on the first postoperative day as compared to both MIS unilateral and MIS bilateral groups. However, it should be noted that about 50% of patients in the open group underwent a monitored anesthetic control as opposed to general anesthesia, which may explain this finding. We also had a small sample size and did not conduct a non-inferiority study. As such, we may be unable to detect smaller differences in speed of recovery between the groups. However, we do believe that wearable activity devices are a novel method to track patient recovery after surgery and may show a benefit of MIS techniques in terms of speed of recovery for other surgical procedures. Thank you.